to the BMI Assessment and Well Visits for School-Age Children and Adolescents webinar. My name is Shamika Davis, and I'm a program manager at the School-Based Health Alliance, and we are happy that you are here with us today. The School-Based Health Alliance is a DC-based nonprofit founded in 1995 and serves as a national voice for school-based healthcare. Our focus includes policy, standards, data, training to support and grow school-based healthcare, particularly school-based health centers. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack equitable access to healthcare services. School-based healthcare is one solution, bringing healthcare to where students typically spend the majority of their time in school. When schools, families, students, and the community work together, students win. I would like to share a few reminders with you for today's webinar. All attendees are in listen-only mode. To ask a question during the webinar, please use the Q&A icon of your Zoom control panel. Closed captioning is enabled for this webinar. To turn it on, please click the CC button on your Zoom control panel. At the end of the webinar, we invite you to complete an evaluation. Your responses are important for helping us to understand how to improve our work. And a copy of today's presentation slides and recording will be available on the School-Based Health Alliance website in the upcoming days. The learning objectives for today's BMI assessment and well visits for school-age children and adolescents webinar are that participants will be able to define body mass index, explain how to assess body mass index at visits, and to identify a program strategy to increase partnerships with students and families. I am happy to introduce our presenter for today, Dr. Ranbir Bains. Dr. Ranbir Bains is a certified pediatric nurse practitioner in a school-based health center and an adjunct faculty at Sacred Heart University with their Doctor of Nursing practice students. Dr. Bains is a 2015 School-Based Health Alliance Leadership Fellow. Before Dr. Bains joins us, we have a poll question that we would like for you to answer. If you can please respond to how would you rate your screening and counseling practices for children and adolescents? Is there room for improvement? Is it pretty good or great? And thank you all for responding, and you're welcome to continuing to respond. Right now, we have 50% of our participants who have responded that there is room for improvement, 30% have responded pretty good, and 20% have responded great. I now am happy to welcome Dr. Ranbir Bains. Dr. Bains?
Thank you, Shamika. That was a nice introduction. Hello, everybody. Thank you so much for joining us today. I'm really excited about sharing what I know about BMI and learning from all of you. So generally, I find like promoting wellness and engagement during all interactions is essential in the overall well-being of children and adolescents. One of the major challenges healthcare providers face is prevention of childhood obesity. Though targeted visits are essential, addressing these issues at all visits is very necessary. So we'll start by defining BMI and then giving you an overview of why it's essential to use it as a tool in addressing obesity. And then we'll end with an overview of programs that have been used successfully in school-based health centers to promote wellness and engagement. So BMI, the body mass index, is a screening method for categorizing weight. It's a person's weight in kilograms divided by the square of the height in meters. It does not measure body fat directly, but it is correlated with direct measures of body fat. It should be used in conjunction with further assessments such as skin fold thickness measurements, diet, exercise history, and family medical history. Next slide, please. Um, so I've always found BMI as a very interesting measurement, and just trying to understand where it came from might give you a perspective on how you can integrate it into your practice. I won't say use it as a single tool because I don't think it's a single tool. So it's not a perfect measure, and it was not developed in healthcare. It was developed in 1832 by a statistician, mathematician, and astronomer whose name I can't say properly, so I won't say it, who had a passion for bell-shaped curves and was inspired to quantify characteristics of a normal man. And to do this, he developed the Quetelet index, which was weight divided by height squared. In the 1950s, Louis Dublin from the Met Life Insurance Company established tables of normal weights for clients after noticing more claims coming in from their obese policyholders. In his tables, he placed clients in 3 categories based on their frame: small, medium, and large. Then in 1972, there was a psychologist by the name Ansel Keys who built upon the Quetelet index and coined the term BMI by analyzing 12 samples of 7,426 healthy men. In 1997, WHO formally recognized that obesity is a global epidemic. Sorry, still in the pandemic mode. So that just kind of gives you a perspective of where the BMI came from and how it's been used. It's not a perfect measure by any means, but it does give us something to start with. So just going back to what it is the weight in kilograms over the height in meters, height squared. And I have some examples both in pounds and in kilograms for your reference. Next slide, please. So next slide, please. Okay, so for adults, the BMI is the same for men and women. Though when I was putting together this presentation, there is conversation within the scientific world on whether that is true or not. But for now, it is the same. So you can see here, anybody below an 18.5 is considered underweight. A healthy weight has a BMI of 18.5 to 24.9. Overweight is 25 to 29.9, and anything above 30 is obese. I put a table in here just for like somebody who's 5'9" and at what weight they would be obese, which would be 203 pounds or more, and under 124 pounds, they would be underweight, just to kind of give us a perspective. Next slide, please. So in children, the BMI is calculated the same way as it is for adults. It screens for potential weight and health-related issues, and it should be checked once a year. BMI trends for children should be evaluated, So if you're seeing a child, let's say every 6 months, it's okay to do another BMI, or even every 3 months, depending on um, the child's how they're progressing. So same thing with children, skin fold thickness measurements, evaluation of their family history, eating patterns, and physical activities should be assessed. And the AAP recommends that these guidelines should be followed starting at age 2. Next slide, please. So what's different with children is that after their BMIs are calculated, they're expressed as a percentile obtained from either a graph for boys or girls or a percentile calculator. So the percentile in children's BMI relative to US children who participated in national surveys from 1963 to 65 and to 88 to 94, 1998, 1988 to 94. So these are like how, so children are compared to other children, in other words, and they get a percentile of how they're doing. So their BMI percentiles look a little different because we plot them on this chart that's shown. So in children, anybody who is under the 5th percentile is considered underweight. A healthy weight is between the 5th and the 85th percentile. Overweight is 85th to 95th percentile, and obesity is anything equal or greater to the 95th percentile. Next slide, please. So defining childhood prediabetes, which is what we really screen for when we do BMIs. The BMI is used for that overweight and obesity evaluation. And again, I think I went over this. This just puts it in a nice slide form to tell you what BMIs are considered a risk for prediabetes. Next slide, please. So the prevalence of obesity in the US, what's alarming is I've been doing this talk for a number of years now, and every year I have to up the stats. We thought during COVID we had reached a peak, but the stats I pulled up for this talk show that it's gone up a little bit more again. So almost 20% of children between the ages of 2 and 19 years are obese. That's about 14.7 million children. And it's highest among children between the ages of 12 and 19, at about 21%. Obesity is common among certain population of children. So compare the obesity rates between the Hispanics and non-Hispanic Blacks and whites. Asians have the lowest obesity rates, and compare this to the prevalence among adults, which is almost at about 40%. So the graph that is shown is from a previous stats. I couldn't find a graph that reflected the current stats that I have in the narrative. So just keep a note of that. Next slide, please. So why are we concerned with measuring BMIs and obesity in children? It's because there is direct and indirect effects on their health. The more immediate health risks are high blood pressure and high cholesterol, which are risks for cardiovascular disease, increased risk of impaired glucose tolerance, insulin resistance, and type 2 diabetes. What we find is breathing problems such as asthma and sleep apnea, joint problems, and musculoskeletal discomfort, which, you'd think, well, these are really adult issues. Unfortunately, we're seeing them in children that are obese. fatty liver disease, gallstones, and gastroesophageal reflux, also known as heartburn. Furthermore, I mean, these are just our physical things. Socially, um, among children that are obese, we find problems with anxiety and depression, low self esteem, and lower self reported quality of life. Social problems such as bullying and, and stigma. Next slide, please. So, obese children are more likely to become obese adults. And adult obesity is associated with an increased risk of heart disease, type 2 diabetes, and cancer. If an obese child becomes an obese adult, the health consequences are more likely to be severe. As healthcare providers, as challenging as this is, we cannot afford not to take action to prevent childhood obesity. This is one of the most urgent issues we face daily. We all recognize children are not in charge of buying and preparing food or choosing where they live. There's growing evidence that to combat childhood obesity, there needs to be a collaboration between multiple partners that includes the community schools, healthcare providers, with families being at the center. School-based health centers are in prime locations and have access to children during the school day. Despite that, it's not easy. Next slide, please. So the recommendations from the American Academy of Pediatrics is to assess all children for onset of obesity-related risk factors, provide tailored counseling by screening the patient and family for stress, disordered eating, and social determinants of health. The CDC recommends increasing access to evidence-based pediatric weight management programs, increase access to food assistance resources. Next slide, please. So let's go into what the clinical guidelines say. The clinical guidelines are summaries of recommendations from pediatric obesity clinic practice guidelines. First, the recommendation is assessment and diagnosis, which is based on the BMI and the BMI percentiles. Once diagnosed, then it's prevention and management, which includes nutrition, sleep, and activity. With nutrition, educating family on eliminating sugary drinks and snacks, encouraging consumption of fruits and vegetables, portion sizes, and regular meal times should be emphasized. Encouraging 60 minutes of physical activity at least 5 days a week and limiting screen time. Giving parents ideas on how to incorporate daily schedules into playing outside and dancing to music. Regular sleep schedules should be emphasized. Regular sleep, and more studies are finding it decreases the likelihood of obesity, and this is across age groups. With behavior modification, educate parents on making healthy food choices, highlight the role of the parent and family in modeling healthy behaviors. When referring children, look for multidisciplinary programs that include not just medical providers, but also dietitian, mental health providers, exercise psychologists, and physical therapists. They should include children and family participation. These guidelines shouldn't be new to anybody who is dealing with obesity. But the question is, what can we do and how can we integrate these guidelines into what we do every day? And we come from many different areas, and I know all of our interests are in providing the best we can for the children in our practice. Next slide, please. So, this is one model that the CDC has developed. It's the whole school, whole community, whole child framework to address health in schools. It's student centered and emphasizes the role of the community in supporting the school, the connections between health and academics, and evidence based school policies and practices. It has 10 components, of which 4 fall under the health and wellness realm. Um, Next slide, please. So we now will shift gears and look at how we can promote wellness in school-based health centers and in the community as well. Um, Next slide, please. So in the community, um, and I have tried these at the school-based health centers where I am. I think they're very, very replicable within communities. Is just a few different approaches, walking groups, to be able to integrate these into your own practice. Um, Encouraging parents to say, okay, what do you do after dinner? Go out for a walk. What I've done within our clinic is that I was able to identify some children and adolescents who were obese and didn't have any place to exercise after school. So, with permission from their parents and the school administration, I set up times either before school or after school to walk with them. Um, and they didn't have to be obese. If they had a friend who wanted to come with them, that was fine too. So it came a little group that kids would chit chat maybe for about 20 minutes before or after school. And and this was difficult. This was challenging in the school-based clinic as well, because kids had transportation issues. If they were taking the bus back and forth, they couldn't come in early. They couldn't stay back. So then what we did is we also provided parents education material through newsletters and school-wide community events. So, and then a few years ago, one of our teachers got a grant to offer yoga to parents and children before school twice a week. That program was a huge success because parents would join their kids in doing that. Um, but like all good things, the grant came to an end. But what was nice was that the parents got involved and the families, they brought their younger kids and they all got to do an activity together. So that's something, to think about, like what can we do that um, we can have the family involved and it's fun. We at our sites have also partnered with local organizations to bring programs into the schools. So our local health council was able to bring in a puppet show and continues to do so to show kids and talk to them about healthy eating. And they integrate some of the diabetes wellness programs into it so the adults can join as well. Next slide, please. So I want to focus the rest of our talk on this one particular program that we had created at our clinic to just promote nutrition and wellness amongst the kids that we see. So this was based off of the Next Steps program, which is a practitioner's guideline to a themed follow-up visit for patients to achieve a healthy weight. So a few years ago, a colleague and I were selected to be part of a QI initiative with the School-Based Health Alliance. We, just like I think there was a couple of questions from the audience, we did not want to look at obesity and we didn't want to make BMI as a focus. So we decided to do this in two ways. Our aims were to increase knowledge of nutrition and exercise amongst selected 6th and 7th grade students with a BMI of 85% and higher, and to maintain consistent engagement in nutrition and exercise among the selected 6th and 7th grade students with a BMI of 85% and higher. We looked for materials that had already been used in primary care and that could be easily adapted for our practice. Next Steps is a publication we obtained from the American Academy of Pediatrics, and it was very affordable for us. It's a guide and a flip chart for clinicians to aid in conversations with children and adolescents about reducing and managing weight. It outlines a series of planned follow-up visits designed to teach evidence-based weight management and strategies. We also gathered handouts and materials that we could send home for the families. Some handouts are shown in the next slides, and they had to be easy to read and useful to the family. Using this as a guide, we designed a 6-session program. We selected 6 students each for a total of 12, and the students who were asked to participate had to meet the criteria for BMI. They had to get permission from their parents and do a pre-test, which we designed with input from other team members. The healthcare providers called each parent to get permission and reviewed the outlines of the program with the parent. We also got permission from school administration to pull students out of their classrooms. Students who participated individually was, so that we could maintain their confidentiality. So they all attended 6 sessions, and they were scheduled 4 to 6 weeks apart. Each session was 30 minutes long. We defined engagement as meeting 4 out of 5 of the engagement criteria, which was attendance, students initiating questions, sharing handouts with parents and guardians, summarizing key points from the session, documenting one behavior change after the previous session. Next slide, please. So the outline for the 6 sessions is shown here. In the first session, we focused on how nutrition affects the body. The second session was focused on My Plate and basic food groups. The sessions talked about reading food labels, beverages, exercise, a guide to eating out, and snacks. At the end of the program, we had a post-test. All students who participated demonstrated improved knowledge and were more comfortable discussing subject matter. This program was easy to integrate into clinical practice because Next Steps has a flip chart designed to help clinicians talk and help children with weight management in a safe environment. Although we allocated 30 minutes per visits initially, it can easily be integrated into a 15-minute visit. I now use it during my annual well checks and acute visits. I have it on my counter, and if I see that, if I want to talk about children, see are drinking a lot of sugary drinks, I just flip it over to the sugary drink area, and there's a section where the child can see the picture, and there's a narrative in the back that the clinician can read out of and ask questions and impart knowledge to them. Next slide, please. So these are examples of some of the handouts that we sent home with the children, and we went over them, and they're very colorful, very bright, easy to read, as you can see. Next slide, please. So, as you can see, um, with each innovative practice, there's an opportunity to build and expand your reach. We all these approaches have been learning experiences for us. So we have also some of the other things I can talk to you about that we have also done is we have created partnered with the school phys ed team and health team and created a food science program which integrates healthy nutrition and exercise into academics. Children have the opportunity to use their maths and science skills. And what they're learning is how to prepare healthy meals from the garden at the school. So they go out there, they, they pick up whatever produce is growing, and the teacher will bring it in. They talk about washing it in a health, all the health involved, washing your hands, how do you prepare food, um, preparing it like with knives and stuff, how to safely use tools to prepare food and then cook it, measure it, where all the math skills and come in and prepare it in a healthy way, and then they all share the food. This program where I am is offered to students who have shown certain behaviors in the classroom, who have shown an interest, obviously get permission from their school parents to do this. The other programs that we have that are running successfully are partnerships with the local YMCAs or the local boys and girls clubs where the children can go in and after school and they have um, you know exercise programs, nutrition programs, academic programs to help them in their overall achievements. Um, the other program that I wanted to mention was a running program that has been successfully running for a couple of years, where the healthcare provider has identified a few kids that are obese or are overweight and is doing a 5K training with them. And then they get to run the race at the end of the program, and kids love it. So, those are some of the innovative kind of practices we have been running at the various school-based health centers that I am associated with. Um, but I'm really interested in learning from the audience as to what they want to achieve or what they are doing at their sites. Thank you. I think that's all I have.
Thank you, Dr. Baines, for a wonderful presentation today. It is greatly appreciated. Thank you for all you have shared about BMI assessments and well visits for school-aged children and adolescents. Okay, so we did receive questions, and Dr. Baines, I'm sorry, something happened with her Zoom. So if she's able to join us later on, we will have you to ask questions for Dr. Baines, but please feel free to type in your questions in the Q&A box, and the School-Based Health Alliance staff will follow up with Dr. Baines, and we will be sure to provide you with a response to your questions. Before we conclude today's webinar, I wanted to share that the 2024 National School-Based Healthcare Conference will take place June 30th through July 2nd in Washington, D.C. For more information, please visit the School-Based Health Alliance website. We invite you to stay connected with the School-Based Health Alliance. We do have a bi-weekly e-newsletter digest that you are welcome to sign up on the School-Based Health Alliance website. And we also invite you to follow us on the following social media platforms. And welcome back, Dr. Baines. I believe you're on, I believe you're on mute.
Okay. Hi, sorry, I think I lost myself somewhere.
It's okay. Thank you. So I believe I'm going to check the Q&A box to see if we have any questions, and please feel free to ask your questions of Dr. Baines. Does anyone have any questions? Thank you. And please feel free to always contact us and we will be sure to follow up with you. Again, thank you, Dr. Baines, for a wonderful presentation today. It is greatly appreciated. And thank you all for attending today's webinar. At this time, we ask that you please complete an evaluation of today's webinar. Also, the slides from today and recording will be available in the upcoming days on the School-Based Health Alliance website, the Health Center Resource Clearinghouse website, and you will also receive an email from the School-Based Health Alliance informing you of when the slides and recording are available for you to access. Again, thank you all for attending today, and I hope you have a wonderful rest of your day. Take care. Thank you.
Thank you.